of patient and family, but also looking at the psychosocial and physical aspect. So, many times there are problems which we are unable to handle from the psychosocial life. And there are many people.
Sunil can't hear you properly.
Sir, actually, there's a issue on my
So it is important for
at least understand the problem, and if there is anything that can be done from our part, we have to do that, or at least we can refer the patient. So we have 2 sessions on mental health care, so which will be taken by Dr. Chitra. So Dr. Chitra, she's I know her for the past more than about 20 years. So she's the founder and the clinical director of Mehet Foundation, which is a not-for-profit organization which is working towards improving the quality of life of patients with mental illness. She and her team actually works in community to see patients with mental illness, and thereby improving the quality of life of the patients and families. She's a senior faculty in psychiatry, and she's heading the Department of Psychiatry at Believers Church Medical College. But she also look into palliative care issues, especially the psychosocial issues and related training and research. She has focused on identifying psychological distress in palliative care population as a part of her research, and has carried out projects both in India and the UK. And as a Union for International Cancer Control International Research Fellow, she did research on screening tools for psychological distress in palliative care in Leeds, UK. She initiated psycho-oncology clinics in Pain and Palliative Care Society, Calicut in 2003, and at Amrita Institute of Medical Sciences in 2008. She is also a national faculty in palliative medicine, and she's a faculty for CADIS International Palliative Care Trust, Scotland, UK. She's also a member of Psychosocial Advisory Panel in PALCARE, the Jimmy S. Billimora Foundation, member of Wabi Sabi Health Foundation USA, and is an honorary senior research fellow of Hull Medical School, UK. And she contributed to the palliative care toolkit, which most of you may know has been published by the World Hospice and Palliative Care Alliance, which is available in several languages. She also holds a diploma in leadership from International Palliative Care Leadership Development Initiative. She was also one of the board members in International Association of Hospice and Palliative Care. So more than this, she's a good teacher, and she's a she has taught me when I was doing my post-graduation in palliative medicine, and she's a friend, colleague, and a mentor for me. So welcome, madam, and it's over to you.
Can you see my slides?
Yes, madam.
Okay. Thank you, Sunil. That was quite a long introduction to me. Can you hear me, all of you?
Yes, yes.
Okay. Thanks for that. Many of the posts that you read out, I have actually the board of directors in IHPC is my tenure is over. So I'm no longer a board member. And so is my honorary post in the University of Hull. That tenure is also over. I just wanted to make that clear. So I want to talk, I just want to tell everyone that today I'm just going to talk about how we make sense of distress, psychological distress in palliative care, as part of palliative care and mental health. I think as Sunil said, we have 2 sessions. So this is quite a long presentation that I've made. And so when you think that this is enough for today, please just raise your hands and put a message on the chat box, because I'll stop there and we can discuss further, and we can continue with the later in the next hour also, next session. So before we, I don't want to lose time. I'll just start off the session. I also want to say that I have a power issue today, power supply. I might go for a few minutes in between if the power goes and the time to, the generator to come back, because my phone data is also very poor today. So a lot of confusion in terms of logging in. So please bear with me. So let's talk about how we look into distress or psychological distress in palliative care. So all of us know, I'm sure many of you have some background in looking after patients with chronic illnesses. So patients with advanced illnesses often suffer or have or experience psychological distress. All of us know that. And while emotional distress is natural, because we know that every person who goes through a crisis in their life will anyway experience distress or emotional distress. But then when people have a continuous journey experiencing serious illnesses and they confront the end of life, end of their life, we need to, as professionals, as carers, we need to know how to differentiate between a normal and appropriate reaction to illness and dying. That means, which would be majority of people who would have who would be sad, who would be fine, who would cope with the great difficulty, but still accept and move on. So that's a normal and appropriate reaction to illness and dying, whereas a more serious emotional state, which can even qualify for a psychiatric disorder like depression. And to differentiate between these two is quite a task. I'm sorry. I'm not able to minimize the screen on the, can someone just minimize the screen of my face coming on the side? I'm not able to do that.
Sripriya?
I don't want this because it's covering
It's
my
okay
slide.
now, ma'am.
I'm not able to do that because the top part of the icons are coming. So I'm not able to really get that link to minimize that screen. I want to minimize that face thing which comes, it's coming on top of my text.
Okay, just a moment.
Can you just minimize that top bar where those icons come, the chat option and everything?
Ma'am, actually, it is remote control. So just a minute. I'm trying to get access.
Anyway, I'll continue. So the context or the background on which we are speaking about psychological distress today is that there is evidence. There's been a lot of evidence related to emotional distress in people with chronic illness, and much of the evidence comes from oncology population, because palliative care actually began with oncology, isn't it? So with cancer patients. So much of the initial evidence of palliative care, and especially psycho-oncology as a specific specialty, came up because of that. And many of the evidence that we have in terms of emotional distress is from oncology population. And there is evidence to show that nearly 60% of palliative care patients experience some sort of emotional distress. So that is one side of evidence that we see. And on the other side, we also see that when there is care provided to the person or the family, where starting from psychoeducation, that is giving information about the illness or the treatment or the prognosis, that actually improves the anxiety, depression, mood, nausea, vomiting, pain. So it improves the physical symptoms perception as well as severity as well, and also the knowledge among patients, adult patients with cancer. So this is the background. So there is a lot of suffering that a person and the family undergoes when they face a serious illness like cancer. So please start, you can put in your thoughts in the chat. I'll take a minute in between to look into what has come on the chat and we can discuss as well. There is another important study which is quite some years back, came from, it came in the Lancet, and it just shows that they looked into reasons for the request of euthanasia. And when you look into this list, you see ultimately the reasons are predominantly psychosocial. So the loss of dignity being the most important reason, and then there's unworthy dying, dependence on others, the sense of being tired or frustrated with life, and of course pain. And pain is actually total pain. It comprises pain in several domains of the life, and it's not only the physical pain. But you see that the reasons are predominantly psychosocial, and I do agree that this can be influenced by cultural factors. And that when it comes from a developed country, there's much more of expression of the personal need for dignity, and the importance of other parts of the domains of life. So let us start with having a example. Excuse me, I still haven't had this go down. Can you please do it?
Ma'am, actually, I had got the remote control, but then
Not, it's covering up most of my slide thing.
just a moment, ma'am.
So let's start with an example of a person that we usually see in palliative care. So this is I've just named that person, Mr. Patel. He's a 68-year-old man with lung cancer with poor response to treatment and now presenting with bone secondary. He's retired from work as a manual, kind of worker. He's a cleaner and he's definitely in financial difficulties. He's recently lost his son and he's supported only by his wife. The issues that he comes to you with is tiredness, being overwhelmed, not sleeping, and getting irritable. So what happens when a person like this comes into a palliative care outpatient department? So what happens is usually our tendency is to look at, yes, this is a person has advanced cancer and he's got bone secondaries. So naturally he'll be having breathlessness, he'll having severe pain or, difficult pain, maybe nociceptive as well as neuropathic. So our tendency is to first address the physical issues. So we attribute ourselves, we assume that he's not sleeping because of his pain or his breathlessness. He is tired because of his medications or because of his physical symptoms, and the rest of the emotional symptoms are attributed to that. So what happens is usually we tend to neglect or overlook the emotional aspect. We have this training in us to condition. We are almost conditioned to look at the physical symptoms more than the other aspects of what the person is going through. So the dilemma is that when such things happen, you think, is it normal for a person to worry after being diagnosed with cancer? I'm sure that all of you would agree that it is normal, isn't it? It is normal to worry. And we know that all of us, any person would worry if they have been diagnosed with cancer to what it's going to bring to them. So then what is the difference between normal worrying and the psychological distress state? So that is what we need to know so that we can identify a person who's got some issues, try to explore them further if possible from your own side, or refer them to a specialist. Let me then go back. So there are people who are not able to really, they go beyond the normal worry and have more mild or moderate or severe distress, psychological distress. So why is this vulnerability happening? Why do some people have this vulnerability? So I'm going back to something which you would have heard, a process called coping. I'm sure all of you would know what coping is. Coping refers to the efforts and processes. It's both psychological as well as behavioral. This is what a person would use to adjust and deal with a critical or a life-threatening situation. And it is not only a critical or life-threatening situation, all of us cope in a daily life with our daily struggles in life, isn't it? So we do that very unknowingly and unconsciously because we have inner resources, and we also use these resources outside us, starting from, friends, family, other support systems, your faith, whatever support system you have, you use that and you adjust to the changes that it keeps happening in your life. And this is especially so, a person has to use it very effectively when there is a critical or a life-threatening situation like a diagnosis of cancer or you're facing with uncertainty in your life. So when a person has to cope, they use strategies unknowingly. All of us do that, and sometimes we use problem solving strategies that involve efforts to address this stressful condition. So how can I fix the condition? How can I solve this condition? So that would be our strategy. Or it could be emotion focused coping strategies that involve efforts to manage the emotions related to the stressful condition. And both strategies are used depending on the situation as well as the person who's involved in it. So some persons would be more problem solving in nature. Some people focus more on emotions. Some prioritize one strategy to a particular situation. So it's a very dynamic kind of process. And we should also know that coping has mature mechanisms as well as immature mechanisms. So we would see a person who's accepted his condition, who philosophizes but intellectualizes and then accepts his condition very. So you might see some older person saying that, I know that I've lived my life. Now I have to accept whatever is happening. I'm happy that my children are settled. I face this cancer that I have got. So that's some normal way. Some help seeking is a mature mechanism, that I know that I have an illness and I seek help to get better or to find out what options have I. So there are many ways, whereas immature mechanisms are many where, one is when there's a pathological denial, that refusing to accept that I have got a serious illness and not complying with the treatment, or, I repress all the emotions that I have within myself and I do not ventilate or discuss with anyone around me. Or I regress. That means regression is when a person who's an adult starts behaving like a child. Some people get very irritable, throw temper tantrums, kind of are attention seeking. They behave like a child rather than adults. So there are immature mechanisms and mature mechanisms. Mature mechanisms help you cope better and get on with the process, whereas immature mechanisms actually add to the problem and your problem becomes magnified. There are two ways of looking at psychological distress. One is the normal or the very usual way, common way of how we would do that in history taking. So we would say that a person is angry, a person is guilty, this person is crying, that person is withdrawn, this person is irritable. So we kind of describe the emotional responses or reactions based on the emotion. Whereas as trained mental health professionals like me, we look at the behavior, the emotions, and the thoughts of the persons as signs and symptoms, which helps us to categorize the distress into psychological disorders and also helps us to share information and have common guidelines for management. So these are the two ways of looking at distress. Now let us look at the emotional reaction. So we say a person is fearful, a person is anxious, but we do not really understand, is there a real difference between emotions? How do we address these emotions when you have an array of emotions? So I'm just giving you some examples. So let us look at fear and anxiety. Fear and anxiety are different emotions actually. See, the psychological suffering of fear differs from the pervasive worry typical of anxiety. Fear is actually an abrupt, unpleasant emotional response, which is caused by anticipation or awareness of danger. There is something going to happen and I'm fearful. Whereas anxiety is more generalized and non-specific because it's got a non-specific threats and cues. You are very worried or anxious because something bad is going to happen. The threat is to the self, to one's existence, and it's actually objectless. So it's a very pervasive kind of emotional state, whereas fear is more specific and directed towards a specific incident or issue or a stimulus. Let us look at sadness, which is another common emotion. So sadness is very different. So all of us get sad, isn't it? All of us feel sad when there is something bad happening in our lives, or when we lose something, So we go through various degrees of sadness also. But this sadness that we go through in a normal life and we cope. So when you're sad, you cope using your, as I said, your coping mechanism, then you bounce back into life. But this sadness is very different from grief, where this is a psychological situation, state that you go through when there is loss, especially loss of a loved one or a dear one. So, or a depression, a depressive disorder, which is a clinical state of mood changes, loss of interest, pessimism, impaired functioning, etc. So both of this take time. Grief is a normal process. All of us would go through it. and it will take time to resolve. Where depression also might resolve on its own, but if you do not treat it properly, there is a chance for recurrence, and the further depressive episode can be much more severe in nature, and the person will find it difficult. So we should know that appropriate sadness happens spontaneously along because, and then coping also happens spontaneously. But with grief and depression, there's almost a profound and pervasive quality. I'm just showing the differences between emotions because we tend to get confused because we just describe the person's emotion. So what happens is that when a person is sad, sometimes you minimize it thinking that this is normal worry, or you kind of exaggerate it and you refer all people who are sad saying that they're depressed. So there is a tendency to use this word, oh, I am depressed, or he is depressed, or she is depressed very casually. And we should not do so because depression is actually a very clinically relevant state. So depression is not a state to be referred to or used very casually in conversations. So when do these emotional reactions become significant? So when do I know, because I'm not a trained mental health professional, when do I know that this person's emotional reaction is significant? I should really think that this person needs help. So what I'm just giving you examples again. So when the emotional reaction, suppose it's anxiety, it's out of proportion to the level of threat. That means if you're planning for chemotherapy, the person keeps on having severe panic attacks. It's not just normal anxiety, but has severe panic attacks, and there is anticipatory anxiety. By the time the date approaches for chemotherapy, this person is very anxious. Or you have persistence of the symptoms or deterioration of function without intervention. That is, there is duration of the symptoms lasting for weeks or months. Or the intensity of symptoms is unacceptable, regardless of the level of risk. Like you have continuous palpitations, or you have insomnia, or even sometimes a suicidal thought or a suicidal attempt. This is so suicidal attempt. You do not wait, a person to observe them for 2 weeks or 3 weeks. When there is a suicidal attempt, that means the issue is severe and they need help. So that is when we think that this person, we have to decide that this person actually needs help. So when we talk about distress, this is a normal way of understanding what distress is. But since we see a lot of distress in palliative care, there have been a lot of frameworks and concepts, standards which have come. There have been protocols, there have been tools to identify distress. And distress is important to understand and to identify because then you actually open up a care pathway for psychosocial care. So when you look into all of the physical symptoms, it's also important that you open a pathway for psychosocial care. And there are also treatment guidelines which integrates with the primary care team. And it is, of course, multidisciplinary, that you could have a social worker, a psychologist, and if you have a psychiatrist who will liaise with you, that is also very good. So, but you need to have some license with a trained mental health professional. I'm just bringing you these concepts. One is loss and grief. This is the most common concept in palliative care. I'm sure you would have been taught about this when you talked about palliative care. You know that grief is very common, loss and grief. We talk a lot about it in palliative care. And there are 5 stages of grief, like denial, anger, bargaining, depression, and then going to acceptance. So this shows like a cycle where the person jumps from one state to another, which is not so. It is not like this actually. It is a dynamic state. It is like waves on a seashore. Like, when at one point when you see a person who is lost and who's in grief, you might see the person is very angry, and then you might see that he's accepted and calm. Again, you would see that he's very desperate. So it keeps going up and down. And finally, by 6 weeks or 2 months, a person slowly starts accepting the situation he is in. This is a normal process a person goes through when there is a loss. This loss can be in any domain of their life or a relationship more commonly. So this is the another common domain we always speak about, because palliative care's definition is meant to improve the quality of life, isn't it? So it's a multidimensional quantification of the patient's functional status. And we have to remember it is as perceived by the patient and not by us. And there are 7 dimensions: physical concerns, functioning, family, emotional aspects, treatment satisfaction, sexuality, and social functioning. It's one of the most research-based concept in palliative care in terms of psychosocial aspects. Demoralization syndrome is another which was contributed by David Hussein. He said it's very different from depressive disorder, where demoralization, he defined this as a state of low morale and poor coping, especially because the person has hopelessness, helplessness, and meaninglessness, and there is a desire to die. That is, there is pessimism and there is a lack of worthwhile future. There is losing the person's purpose in life. So this is termed as a demoralization syndrome, and evidence, the study he did, he said there's around 20% of people with advanced cancer has demoralization syndrome. I'm just bringing you new various concepts. You did not really know about all these frameworks. It's just, but from your side, I would expect all you to understand what distress is and identify distress so that you know what to do further. So let us go into distress. So distress, this was contributed by the National Comprehensive Cancer Network in US. And this was meant to be a common platform from which you can move ahead. So distress is defined as a multifactorial, unpleasant emotional experience, and it is of a psychological nature. So it's got cognitive, that means the thinking part, the behavioral part, and the emotions. And also it impinges with the social and the spiritual aspect. So what happens when you have distress? It interferes with the ability to cope effectively with cancer, its physical symptoms and its treatment, and it extends along a continuum. So the distress can range from common normal feelings of vulnerability, sadness, and fear to problems that can become disabling, such as depression, anxiety, panic, social isolation, existential and spiritual crisis. So it's a very broad concept, which is multifactorial, but it is unidimensional. I hope you understand when I say unidimensional. That means that you can only say whether there is depressed, when there's distress or no distress. When you assess for distress, it is unidimensional. So distress is a dimensional construct. Like I said, it's unidimensional, but it can be categorized into psychiatric disorders or psychological states like adjustment disorders, depressive disorders, anxiety disorders, or states of distress like demoralization. Or you can even say, because during COVID times, we became very familiar with burnout, isn't it? So there's moral distress. So there's a lot of states of distress also that we know of. The prevalence of psychological distress varies due to the type and stage of illness, that is the advanced illness, the patient's age, gender, and race, as well as the definition of distress use. And it also extends to existential crisis and spiritual suffering. So questions like, why is this happening to me? What did I do wrong? Why me? Why is God punishing me? Why am I living? I don't deserve to live, or I have to really not be a burden to others. So this is all which comes as a it is not only emotional issues that come, but it also impinges on existential questions and also on the meaning and purpose of one's life. I'm just going to take a minute here so that you can ask me questions. I have to meanwhile search for the panel again because I can't see the okay, I can see the chat. So there is one question. I'll just see how many questions are there. Okay. Madam, most of the patients of advanced cancer are obviously in depression, though they don't say so. In these cases, do we start antidepressants regularly, or should we evaluate the patient and only then start the medication if very much indicated? So, Dr. Biju, I hope the initial slides actually helped you, because
yes, it did, madam.
Yeah,
Yes.
I don't think you can generalize that everybody is in depression. I don't think so. I don't think sadness should be just assumed as depression. You need to assess them, evaluate them. If need, take the help of a mental health professional. Dr. Punita asking, Madam, please tell us about handling insomnia with and without pain. Any resources to refer to? Are there special therapists or teleservices for that? Okay, I have not touched on insomnia or sleep disturbances here. What I can do is, if we finish this session today, you can actually write to me saying what topics you want for the next session that we do on 26. I can work on that, and we can have 2 or 3 small topics and we can discuss about that. Or if you can give me a list of questions, we can just interact and answer the questions as well. So for Parul asking, can patient go from acceptance phase to denial phase? How to intervene? So see, when it's coping with, or the person is uh, going through these phases of adjusting during grief or during a process of adjustment after getting a diagnosis of cancer, what you do is provide them a supportive care, empathetic listening. Do not try to solve their problems immediately, but be with them, ask them how, why, and get on, help them, facilitate the process of them reflecting on what they are going through. Only denial is actually a person not, the denial phase also can be a way of coping, which is normal. Pathological denial, when they refuse to comply with the treatment or refuse to come to follow up, that is when you intervene. That means that you have to really talk to them, talk to the family, and find out what we can do to help the person get treatment. Unless the person refuses treatment and you have a discussion with the family and your team, whether we respect his autonomy or whether we have to go ahead and listen to the family. So that's a whole lot of how we resolve that kind of an issue. Then you have Saravanan asking, ma'am, distress can be used as a preliminary diagnosis to start with. Then we have to narrow down by evaluation. Am I correct? Yes, absolutely. The basic thing is, I would say that you start off initially to identify the distress. So that would be the first step that would help. That can be done by the primary care team, whether you are in any department. I'm not saying only palliative care, because people everywhere in any specialty will have distress. So what you can do is, within your team, you can actually start screening for distress, of which I'll come to you now. We'll be talking about distress and screening also. So how does distress impact outcomes? The main thing is, people probably, they get the distress actually impairs so much of their quality of life. They also start, they have a very poor quality of life, poorer quality of life, I should say. And then because of the, distress itself, they become non-compliant to treatment. Even not only to the psychological aspects, but also they might not take the analgesics we prescribe or other medications. They might not come regularly for follow-up, or even during home visits, they may not really cooperate with us. They may just turn their head to the other side. And sometimes the team members come and ask, what do we do, madam? This person is withdrawn. He's not answering our questions. He just he just lies facing on the other side, looking at the wall. What do we do with this? So those kind of outcomes are possible. It can also negatively impact survival of the person. There is increase in treatment burden to the primary team and health system. That is, there's longer hospital stay, increased costs, less efficacy of the treatment for the other aspects of the illness. When you're emotionally distressed, there is higher perception of pain and other symptoms. So how much ever medications you give, sometimes you use, sometimes pain is not really, doesn't respond to enough analgesics, because there is a good amount of distress, which is giving them a higher perception. There's a burden for the family, and of course a higher risk of suicide as well. So why do we want to screen a person for distress? Like I said, we need to identify a person with distress. So why do we need it? Because screening, if you have a screening system, it will actually improve the timely management of distress, and also it will help the psychosocial intervention, which reduces the distress such as depression, anxiety, if they are particularly pre-screened. So if you're pre-screened, you are prepared. The person also understands better that there is something happening to me emotionally, and is also prepared to receive the psychosocial intervention. So the NCCN guidelines, which you can actually search for on their website, it recommends routine screening for distress and as appropriate referral for further assessment and support. So this is seen as a requisite in all, as in the guidelines, in many settings. Like NICE guidelines says this. Then you have the Canadian Psychosocial Oncology Group actually has distress as the sixth vital sign. So there is many developments in many settings. How do we measure distress? So I want to say that yes, screening is very important, but it's not to have, screening itself is not sufficient to improve the patient's outcome. It helps you identify the people, but it does not diagnose. So you should understand that screening is just the first step. After that, you need to know how to diagnose. If you cannot, you should know when to refer. but it is a necessary prerequisite to identify people who would benefit from evidence-based treatment and guidelines. But still, even with lot of evidence and lot of research happening, a cross-sectional survey of 20 institutions reported only 60% of services conducted outpatient distress screening as outlined in the NCCN standards. So this is not happening in all oncology or palliative care settings, but it is absolutely needed. So how do we screen? So let me get into what we can do in our clinical practice. So this is essentially by using tools and questionnaires. So I would point out distress thermometers, the easiest that you can use in your setting. There is ISAS also, that is the Edmonton Symptom Assessment System. These are unidimensional. Multidimensional scales, you have a lot of them, like the Hospital Anxiety Depression Scale, which is a questionnaire with items, GHQ-12 or General Health Questionnaire, which is again a questionnaire with 12 items. Patient Health Questionnaire, PHQ, is also very, very relevant to, you can actually use it in your setting if you have the competence, or if you have a social worker, or you are going to develop a core team, look into it. You can look into the evidence which uses PHQ and use it after screening. You can actually do a two-stage assessment with PHQ-2 followed by PHQ-9, because PHQ-9 is almost, that questionnaire helps you in diagnosing depression. So the studies show that PHQ-9 is as robust as you do a mental status examination by a psychiatrist. You have the Integrated Palliative Care Outcome Scale, IPAWS, which is a palliative care outcome scale in palliative care settings, but has the emotional aspect as well. And I also say that qualitative methods like asking questions, interviews, and focus group discussions, especially for research purposes, also help us understand more about distress. So again, going back, does screening help? Yes, screening enables identification and initiates a pathway for psychosocial care. But remember that a gold standard is always a detailed mental status examination, especially by a trained mental health professional. So if you're planning a research, remember that just screening with you did have a lot of research initially in psycho-oncology where people just use scales, rated the sadness with scales and said, this person has depression scores, this person has anxiety scores. It is good to understand, but it is not robust methodology, because we need, when you talk about specificity, when you talk about a person's diagnosis, you need a mental status examination by a trained mental health professional, or you need at least a structured examination. You have several methods like SCAN, SCID, etc. Not going into the details of that, which are very robust methods for diagnosis. So we need to have a good correlation with diagnosis by a professional as well. So again, distress thermometer, which is easily, you can download. It's the most widely used rapid screening tool. It's just a thermometer. I'll be showing the picture just soon. It's a requirement of most professional bodies and guidelines for supportive and palliative care to use such tools. It's more acceptable, easy to administer. There is less stigma, and it's much studied. The stigma is that you're not saying to a person who's already feeling stigmatized with cancer diagnosis or some other chronic illness, you're not telling them, see, you have depression, you have to see a psychiatrist, which in spite of all the progress that our society and our medical fraternity has made, still there is a stigma for a mental illness or mental health, and there is a stigma within medical fraternity. The easy referral to a psychiatrist is still not possible. People take their time, people think they can manage, and most often we get it when it's quite difficult. So the stigma is very important in terms of, so distress was used so that a person, we can tell the person, you have distress, you need help, rather than saying you need help for depression. Am I audible?
Yes, yes.
Yeah, I think the power went to the, I think that's where. Okay. And we should also remember, if you're planning research, future research must compare either with qualitative interviews and the true gold standard, like the mental status examination. So this is the distress thermometer. So you can see a thermometer here with the 0 correlating to known distress, and 10, the maximum score is extreme distress. So a person is asked to score from 0 to 10. So see these instructions, please circle the number 0 to 10 that best describes how much distress you have been experiencing in the past 1 week, including today. Okay. So this is what we ask the person to do. And this has to be done regularly and routinely. It is not enough that you do just for the first visit because it keeps changing. And this is a problem list that the distress thermometer guideline brings. Whereas, and this is very culture specific also. So you have physical concerns, you have emotional concerns, you have social concerns, you have practical concerns, you have spiritual or religious concerns and other. So this helps you because if you're going to do this at the first or the second visit, you mark what is the priority of these issues that the person has. And then when you manage the person, sometimes the next visit or the third visit, you see that the issue changes. So maybe the physical concerns when you manage pain becomes less, and then it is more the social concerns or the practical concerns. And you can always adapt this list to your own settings. And also, it's also important that you use the appropriate term for distress. I don't know how many languages so many languages people speak in India. So you can decide and you can put on chat of how distress is, the word that you use in your own language. We found it very hard to find a word in Malayalam. There is no exact word that translates. So in Hindi or any other language, if you have a term, you can put it on chat. There is also some evidence regarding a distress thermometer, which we did in India. One is a study which I was a part of. This is what we did in the UK. We compared the distress thermometer with brief symptom inventory 18 and the GHQ-12, and we correlated it with the gold standard. So, and then we did it in a palliative care population, and we did it with an optimum cutoff of 5 in the population. Remember, some research also recommends cutoff score as 4. We saw that in the study, 34% of the patients satisfied ICD-10 criteria, which is the International Classification of Diseases 10. It was in 2006 or 7 came out. The study, the publication came out in 9. Now it is ICD-11. We have progressed to ICD-11. So they qualified for a psychiatric diagnosis, and adjustment disorder was the most common one at 22%. There is another study where 56% of patients had clinically significant distress, and patients with low socioeconomic status had the highest distress among head and cancer patients, and this was done in India. So I'll also talk about PHQ-2 and 9. PHQ is a self-administered version of the Prime MD, which is a diagnostic instrument for common mental disorders. So WHO classifies mental disorders as severe mental disorders and common mental disorders. Severe mental disorders are schizophrenia, bipolar mood disorder, much more, severe in nature, whereas common mental disorders are the stress-related disorders, depressive disorders, anxiety disorders, etc. And a 2-stage screening, like I said, PHQ-2 and 9, coupled with collaborative care for depression, appears to be significantly less expensive than most clinical preventive interventions. So screening with PKP, but this is only for depression, because PHQ-9 is especially so for depression. You have specific tools for anxiety as well. And both PHQ-9 and PHQ-2 have good accuracy in discriminating cancer patients with a mood disorder. So you can actually look into that as well, into the evidence of PHQ-2 and PHQ-9. The integrated palliative care outcome scale, IPOS, aids in screening for distressing needs and track their progress. It has got excellent reliability for a clinical measure in assessing the overall palliative care needs of a patient. So this is about overall palliative care needs, of which one would be emotional needs as well. Other tools to use, there is another tool called DAS-21, which people are using very recently. People are using it more. It is called the Depression Anxiety Stress Scale. So see that it has got 3 domains there. One is depression, anxiety, as well as stress. So again, this is, it is not a diagnostic scale, but it helps you get these scores for depressive states, anxiety, as well as stress. It is a 21-item self-report questionnaire. It's increasingly being used, especially in humanitarian settings or vulnerable populations. I hope all of you know that palliative care in humanitarian settings is also really happening these days, especially for refugee communities where there is conflict. When we had the floods, etc., palliative care had a very important role during the COVID-19. So these are all humanitarian settings and vulnerable populations. I'm involved in an ongoing study on exploring the needs and lived experiences of people with chronic disease among refugee and host communities in North Uganda, and the experience of village health team workers in providing palliative care. So it's a very interesting study. There's another 9-item brief screening tool, STAR MH, which is an easy to administer tool for asylum seekers and new refugees. What I'm trying to tell you is there has been progress in the way that screening is happening as well. You're not doing it only with one tool. Of course, distress thermometer is what I would recommend to you to use in your own settings. But if you are working in, in a humanitarian setting or with vulnerable populations, you can also look into evidence, looking to task 21 or, STAR MH. Then, of course, qualitative methods, which is one of the, recently we see most research having mixed methods, or, other than quantitative, you have qualitative methods also. And this is very important when you look into subjective states like distress. But qualitative methods is not only to explore distress, but it also it can be used to evaluate your programs. Suppose you set up a pathway for psychosocial care, you can evaluate your program using a qualitative method. You can understand the experience of the stakeholders and also generate new hypotheses. So mixed methods, there is a study which was done to explore psychological distress with collusion in cancer patients. There is the evidence for that. You can read about it if you're interested. Just giving you examples of how research is helping us to understand this. I have been involved in studies with women with breast cancer, and there's been a series of evidence. And one was a systematic review to understand distress. So this gave us insight that culturally congruent care, including accessible communication information. That means there should be good communication skills and appropriate information, along with which will lead to culturally congruent care. That means the care that you give, especially psychosocial care, should be congruent with the culture of the person. The settings, it's adapted to the settings from which the person comes from, including language, the way they express distress. Everything is very important. And if you have such care, it helps prevent and alleviate distressing symptoms, whether the people are in India or as part of a migrant community elsewhere in. So Indian community in other parts of the world, globally also, they need culturally congruent care. This study with voices with women with breast cancer, we looked into qualitative data, looking into the voices of Indian women with breast cancer, describing their suffering, and 3 major themes emerged. The themes were far-reaching psychological distress. The one important theme was getting on with life and the importance of a support system in their lives. I'm just giving you some insights regarding the quotes that we got from this study, which is, I think, very important to understand. Just giving you glimpses of how people actually express their distress. So look at this on the right side. I lost a lot of hair. I had long, thick hair. So I was very sad when I lost my hair. My hair was not even gray. It was still black in spite of my age. So this is very important culturally. An Indian woman is very, proud of her hair, as well as the identity of being a woman, so much related to her hair, isn't it? I think most women worry when they start losing hair. So this is very important for this person. All people used to comment on how my long black hair was, but now everything is gone. My daughter has got a wig for me. I used it a couple of times when I went to the temple, but when I used it, I felt very strange. So this is about body image. So the concept that you get from this is body image. That person is worried about that. Let us look into, I was also very angry initially when I reached home after chemotherapy due to the discomfort in my body. I used to get very angry, and I used to speak angrily with all my family. I used to answer back to my family members, so my husband was very angry with me. So how the expression of emotions actually also influences or impacts on the family. So that is what it shows, and how emotional distress keeps, reflecting or, impacting on other domains of life. There are good things also. His counseling is the reason I am so strong mentally. Initially, I was scared. My daughter's working in Bangalore. I have only my husband with me, so I had a bad feeling. But the doctor and his words, the person cries, and then I had no problem, had full confidence. I will recover from this. So this also shows how a therapeutic relationship, or what the rapport and the relationship that you establish with the person who has the illness or is going through treatment, is very important. how your communication, how your offer of supportive care really helps the person cope. The other one, I think it is a good idea if other people are able to know about us and understand our problems. I know a person who comes here and I talk to her and I encourage her to think more positively. So I believe that others who hear this will benefit from it. I believe those who had the disease are able to talk more about it. This really talks about the support that people with lived experiences of the illness can offer. That is a peer support group, which should be encouraged, which actually helps the person with the illness in a very different way than how we as carers would provide them. So let me get back to distress again, because we now talked about what is distress. We talked about screening of distress. We talked about how people express, isn't it? But when we are looking into assessment clinically, we should know that it is unidimensional, because it's very important that is to understand the concept of distress, because it's dynamic and it's unidimensional. Look at this, this spectrum here from green to red. So you look at a healthy person, apparently reacting to a situation, getting injured, and then going to an ill state. So when a person is healthy, we assume all of us may be healthy, we have normal mood fluctuations. We are more or less calm and we take things in our stride. We have a good sense of humor. We are performing quite okay. We are in control. We have more or less normal sleep patterns. We have few sleep difficulties. We have good energy. We're physically and socially active. And hopefully we have limited substance use or other ways of immature ways of coping, like gambling or alcohol use, etc. So when there is a difficult situation in our life, we start reacting to it. We become a bit nervous, we are irritable, we are impatient, we become overwhelmed. We start becoming procrastinating things, become forgetful, there is trouble sleeping, intrusive thoughts. Physical symptoms come like anxiety leads to muscle tension, headaches, low energy. There is decreased activity. Sometimes some people, because they cannot cope, will start using alcohol or any other substance, or getting into other activities like gambling. The reaction goes into an injury. That means the disease status magnifies. So the irritability goes into anger, the nervousness becomes anxiety, there is a pervasive sadness, hopelessness, poor concentration, restlessness, disturbed sleep, recurrent nightmares, increased aches and pains, fatigue, avoidance and withdrawal of the person, increased alcohol use, and then you get into an illness state where there is angry outbursts, aggression, violence, excessive anxiety, panic attacks, depressive states, suicidal thoughts, not able to concentrate at all, can't fall asleep, or your insomnia is there, sleeping too much also is seen sometimes, physical illnesses, constant fatigue, not going out at all, not answering phone at all, alcohol dependence or other dependence. So see, you can see a person in any of the spectrum. So we should know how to discern between these states in when it's a unidimensional status. So let us go back to Mr. Patel. So before that, let me just ask you whether there are any questions. Just take 1 or 2 minutes. Okay, ma'am, what is the difference between unidimensional versus multidimensional? So unidimensional, like I said, Parul, it just helps you to identify whether that condition is there or not. So it's only a dimension, that dimension of distress is there or not. Whereas when it's multidimensional, you get several categories of the states. Like, for example, is categorizing as depression, anxiety, adjustment disorder, when a psychiatrist sees. Or it could be like when you have a questionnaire, you have scores for different states, like the DAS-21 I said. Is that clear?
Yes, ma'am. Yes.
Okay. So, ma'am, can these tools be used in non-cancer palliative care settings? Absolutely. There's now research where these tools are being used in non-cancer settings as well. Non-cancer palliative care settings. Even if it's not palliative care, also distress thermometer is looking at distress. So you can actually use it. You have to just adapt the problem list in a different way. Any other questions now, or can I go ahead?
Please go ahead, madam. We will take the questions back.
Okay. Okay. So let us go back to Mr. Patel. So when we assess the person, so we see we are going through a pathway now, isn't it? We have understood what distress is. We know that we need to screen, and distress thermometer is one tool that you can use in your settings. And Mr. Patel is sitting in front of you, so you know that he's distressed by his non-verbal and verbal kind of communication that you have, but you also have to access in the history, you have to ask certain things, some pointers towards mental health issues. So does he know about his illness? It's very important to know whether he knows about his illness. Does he worry about the losses? Remember in history, I said there is a loss. He lost his son recently. So how did that happen? Was it a natural or was it a traumatic death? Was it a suicide? How is his relationship with his wife? It is supportive or is there a conflict? How did he cope in the initial stages of cancer? Because he's come to you and he has an advanced state, bone secondaries, isn't it? So how did he cope in the initial stages? Are there any reports of his nature being a worrying type of person? Some people are, the personality is very important. Some people have a anxious kind of personality traits. When they have neurotic traits, then that itself pushes them into becoming more anxious. Who is supporting him? Are there any resources for emotional as well as other support available? Is there any neglect? So that is a very important question, especially when it's an elderly person. It's a person can be easily neglected by their family. What are the risk factors? For example, if it is anxiety disorder, what should alert us to identify anxiety or any other distress state? One is trauma, history of traumatic events in the childhood. Maybe sometimes we may not get the detailed history from his wife, but I'm just giving you a pointer. Chronic illness, like this person has cancer, negative life events, like the person's loss of son, personality, like anxiety traits, neuroticism, avoidance of poor coping behaviors, gender. Female is a more at risk of common mental disorders. Not all the psychiatric disorders, but definitely for anxiety as well as depression. Whether there's a past history of mental health disorders or treatment, whether there's a family history of mental health disorders and treatment, very important, which includes substance use. Presence of other mental health disorders like depression or substance use, chronic pain, recurrence of the disease, disfigurement or embarrassing issues like colostomy, visible scars, body image disturbances, etc. All risk factors for the person to have emotional distress. So let me also give you an idea of how we look into psychological distress in terms of manifestation. One is the emotional aspects. So I remember I said emotion, behavior, thoughts, etc. So we do not just look into the emotions, but emotions as well as all other aspects. Emotions is either the person is feeling stressed or overwhelmed, feeling anxious, worried, sadness, low mood, irritability, difficulty concentrating, trouble relaxing. So this is the emotional aspects, the physical. So remember, other than the physical symptoms of the illness, the person can have physical symptoms of the psychological state, like palpitation, increased heart rate, restlessness or agitation, stomach upset, multiple aches and pains not associated with fever. Behavioral aspects like fatigue, or uncomfortable sensations in the body, changes in eating pattern, difficulty sleeping, aggression, and also I would also add sexual aspects also. We should look into sexual functioning. Then there could be worsening of the pre-existing symptoms, like either the worsening of ongoing mental health problems, worsening of chronic health problems, or increased use of alcohol, tobacco, or other substances. But the red flag signs are agitation, confusion, disorientation. Disorientation means orientation, like for delirium. If you have already been taught about delirium, you would know that a person's higher mental functions are to do with the level of consciousness, confusion, disorientation, that is orientation to time, place, and person, and of course, memory. So if all this, the higher mental functions are affected, definitely they need help. Substance use, psychotic features like hallucinations and delusions, and of course, very importantly, suicidal ideation is a very strong red flag sign. So when you, again, to repeat, basic steps in assessment is screening, listening, using your appropriate communication skills, asking the right questions, interpretation of the mood and symptoms of the distress state like anxiety. So how deep is that is this sadness? Is it just short-lived or is it profound? Is it pervasive? It is affecting the person's functioning. So link the mood with the person's functioning, like the biological functioning, that is sleep, appetite, sexual functioning, his social and occupational functioning, interpersonal functioning, that is the relationships that he has with friends and in the society. So when you link with the person's functioning and you see that the person's functioning is impaired, so his sleep is terribly disturbed, he's not able to really function at home, or he's not able to go for work, then that means his coping is affected. That means there is distress which is not able to cope. So then you need to diagnose which category of distress he falls into. So when distress is more than 4, he definitely needs more support. If possible, interventions from a specialist. For mild distress, usually we give psychological interventions only. When moderate to severe, more often need an addition of a pharmacological management. So in Mr. Patel, when we screened with distress thermometer, he showed that he scored 5 for 2 consecutive visits, indicates that he should be evaluated even when the distress is associated with physical symptoms like pain, etc. If possible, by a trained social worker, psychologist, or a psychiatrist. So when we are exploring, then you look into which category of distress this person is falling into. Is it part of an adjustment disorder? It's the commonest psychiatric category that you would see in a palliative care population. It is a maladjustment process in response to chronic stress. It is usually short-lived, and they have a mixture of symptoms, a labile state, emotional distress, anger, fear. It's a very labile kind of emotional state, but usually short-lived, and they either resolve, they get back into a state of acceptance, or they go on into a depressive state. So adjustment disorders, the prevalence rates range from 30 to 50% of all cancer patients with depressed, anxious, or mixed features. It's got an intermediate status, and there's a lack of specific list of symptoms which raise problems in diagnosis. Because when I say labile state, you would be confused. But then it is the commonest. You can read about it. And diagnosis is just a means of identifying a response which needs follow-up and treatment. So you need to understand that this is not depressive disorder, because the commonest category is adjustment disorder. So earlier, when you look at the research, you would see the range of depressive disorders in palliative care population range from 5 to 50%. So remember, it depends on the methodology that you use. So when you use specific methodology, you see that the prevalence of depression is only around 7 to 13% actually. So from 22 to 35%, it is actually adjustment disorder. So they can actually, if they get supportive therapy, they can get back into a state of acceptance. So what is a depressive episode? So you have 3 main criteria that when you diagnose depression. See, I don't expect you to really diagnose depression, but just to understand that there is actually a different category when we look into sadness. So this is all emerging from sadness and anxiety. And when you look into sadness, see how we have categorized into the several psychiatric disorders. So the main 3 symptoms is depressed mood, low mood, loss of interest and enjoyment. So that is called anhedonia, ANHEDONIA. Loss of interest and enjoyment of activities that the person used to enjoy before. Reduced energy. So this is the main 3 symptoms, and other symptoms are reduced attention and concentration, reduced self-esteem and confidence, ideas of guilt and unworthiness, bleak and pessimistic views of the future, ideas of self-harm and suicide, and changes in body function, sleep, and appetite. You can see that I have marked some in red and with an asterisk also, like depressed mood, loss of interest and enjoyment, ideas of guilt and unworthiness, and ideas of self-harm and suicide. That is because they are more of the psychological symptoms. When you're looking to reduce energy, reduce attention and concentration, changes in body function, sleep, and appetite, they are more the somatic symptoms of depression, which can be present in a person anyway who has a illness like cancer. Like a person with cancer can have sleep and appetite disturbed, can have reduced attention and concentration, can have fatigue. So you cannot really say because of these symptoms that the person has depression. So the other psychological symptoms are very important to be identified to diagnose depression in such people. And what are the features of the common types of anxiety disorder that you should know? So the types of anxiety disorder a person can have are panic disorders, generalized anxiety disorder, anxiety as a part of adjustment disorder, anxiety as a part of depressive disorder. So anxiety can be a symptom as a part of adjustment disorder as well as depressive disorder as well. So in panic disorder, you have physiologically, the physical symptoms is that you have palpitations or racing heart, the person is sweating, trembling, shaking, feeling a shortness of breath, feeling of choking, chest pain or discomfort, nausea, dizziness, chills or hot flushes, numbness and tingling. The person thinks that I'm going to have a heart attack, I'm going to lose control, I'm going to go mad, I'm going to die. These are the cognitive or the thoughts that the person has. I'm going to lose control. And those thoughts are very important to identify. So that shows that this is not actually a cardiac condition or a heart real, emergency to go to the emergency room, but more of a panic attack. in a generalized anxiety disorder is a continuous excessive anxiety and worry for at least 6 months about a number of events and activities like money, job, security, marriage, health, etc. And the person finds it difficult to control the worry. We would be very familiar with people like that who are always on the edge. So how do we manage distress? So it is like 8:10. Do you want me to go ahead, or do you want to discuss based on these what we have spoken about till now?
How many slides more are there?
I think management would be there, maybe around 10 more slides.
Okay, we can take questions and then we will see.
Okay, shall I stop the share now?
Okay. I can see a question here. To identify distress after how many visits with patient should we start assessing, as asking such questions are usually difficult when we are meeting them for first time.
Sunil, you're not very clear. Let me to identify distress, how many visits with patients should we start? Okay, that's a very difficult question to answer because again, it depends on the intensity of the distress. So I can't say that you have to wait for these many visits to address the psychological distress because you wouldn't ask the same question if it's a physical pain. If I ask the same question about if the person has severe pain, would you find it easier to ask them about the pain? Why do you find it difficult? Why do you find it difficult to ask about psychological distress and not about the physical pain? That is a question we have to ask about ourselves.
Ma'am, what I meant to ask was the patients are usually not comfortable to discuss their inner emotions initially with us.
I don't
Even
know
if
if it
it
is
asks, I
I
don't know.
I
Yeah.
don't know if it is a patient or it is us.
Oh my.
I will tell you why. It is not because I'm not being judgmental or critical. And what I'm trying to say is because we in our medical training, we are so used to looking into the medical model, isn't it? And you're very comfortable asking. You're trained to ask about the physical symptoms, but you are not trained to ask about how do you feel.
Yes.
So when a person, even in palliative care, when a person comes for review, usually you would ask, how's your pain? Do you have constipation? Do you have vomiting? So the questions are mostly related to the physical symptom and the side effects due to the medication. But an open question like, how do you feel? Can you tell me how you're feeling, how you're coping? A person will never have a problem answering that. Think of yourself in that state. Would you feel happy if a person asks you, how do you feel?
Yeah.
When you are going through some issues, sometimes you think you do not want to talk about inane matters. You want to just talk about your emotional issues. So when someone asks you, how do you feel, or can you tell me? Because if you look at Mr. Patel, he's coming with irritability, difficulty in sleeping. But what happens is, like I said, we attribute it to the physical symptoms. And then we start asking, oh, do you have so much of pain? And we assume that all this is because of the physical symptoms. So rather than that, I would probably ask him that, can you tell me more about your difficulty in sleeping? Or can you tell me more about your wife is saying that you're very irritable. Can you tell me why it's happening?
Yeah.
I think it is our helplessness and then we kind of put it on them because we are not actually, we are so we find it hard when the person starts crying or, says very difficult things like, I don't want to live with this pain or something. We find it very difficult, but we are okay when the person has difficult pain or something, when we know that morphine is really not acting. We are able to reassure them that we are trying our best, but the pain is so difficult kind of thing. But you should remember that the psychological distress is also a similar symptom. So, but I do agree that maybe you will take time. So you can probably do it after you establish your rapport and have a therapeutic relationship. So maybe the first visit would be to understand more about what he's going through in terms of all his concerns, all the 4 circles that we talk about in palliative care. And then you can probably in the second visit ask him more about it. But we should also know that if the psychological distress is so overwhelming for the person, we cannot postpone it.
Yeah, definitely.
Is that clear?
Yeah, definitely, ma'am. I have one more thing to ask and share.
Yeah.
Usually in India, there is kind of a gender disparity between men and women. Like men are supposed to be very strong and all. So to ask the distress and such kind of questions, especially to the male gender, I don't know. I don't have that much of an experience. Have you seen the difference
Yes,
between
yes.
men and women?
Can I mean, I want the other people also to reflect on this. If somebody has anything, please put it on chat, because I don't want to answer all the. This is a very, very important, relevant because it's a culture that we live in, and of course, men are expected to be. I don't know if men are strong, but men are expected to be strong. It is a stereotype in the psyches that we have grown up with in our society. We expect that men also expect that we should not cry, and women, and they think that women are weak also. So it's both sides,
Yeah.
Women can cry.
Yeah.
So, but when it comes to emotional distress, it's almost the same between man and women. I mean, it is the risk in which the distress states that they have might be different, or the risk of behaviors. Maybe in some cultures, substance use would be more in men because women who do not have an access to the substance. But these days, it's not so. Also, it is becoming a more or less, women also consume alcohol and smoke and all these things. But there are some cultural factors which can determine how these states are expressed, or like women usually in our setting, we in mental health, we also say that women might not even get the equal chance like a man to come and express about their mental health issues with a doctor.
Yes.
So that is one issue that we say about gender disparity in mental health issues. And because it's easier for a person because of the stigma, people would come and express their distress states as physical symptoms. Like a person who's depressed, usually they would say, my head is heavy, I'm very fatigued, I'm very tired. So that is why you have a lot of people expressing physical symptoms even when they have psychological distress. It is because of the gender as well as the cultural factors, the stigma that mental health issues carry. But I think as professionals, I think we should be asking both genders in a similar way. Of course, your communication skills are very important in the way that you establish rapport, the way you make things private and confidential. And if you want, you can say that I'm going to ask you more about how you're feeling. Is that okay with you? And then you get on to ask.
Yes. Thank you, ma'am.
Madam, in my practice, what I have found is that men are actually weak. Women are very strong because they carry on with the disease in spite of the fact that they are suffering. But at the same time, men, when they face the real facts, they usually succumb to the disease faster than the women.
I don't want to say without evidence, because I don't know. You can look for evidence if there's any.
No, I see that most of the time
that is our experience,
Yeah.
That is the experience, because I think it is also because men have to cater to this, like I said, this stereotype that society expects of them. And when they suddenly lose that control of, their identity, their role that they have been used to being the domineering person in the society as well as in their family, the person who's bringing in money, the person who decides everything, suddenly they are in a state of where they have to depend on everyone else. So that puts them in a state of being very overwhelmed and vulnerable. So we need to understand them rather than, I don't want to judge them, but I think men go through that in a very different way than women. And women, when you look at male and female psyche, when you look, when a man was, you should look at man as a hunter, initial primitive thing. So man's job was to go and hunt for the food. So it was provider. So he had the single focused approach to life. He goes out, hunts, brings. Whereas that's why if you see in the animals, the female species is much more seen as, aggressive, and, because it has to take care of its progeny. It has to also provide food sometimes. It also has to take care of the boundaries. Not anyone, let anyone come into its boundaries. And also in charge of the reproductive, to bring in more into their tribe. So a woman actually, probably what I would say is, as a psyche itself, woman is much more trained to be from those times as a multitasker.
Yes.
So probably a woman, that's what women do these days. Like they do work for outside, they come home, they take care of things at home. They also, they do multiple tasking quickly, which a man might find it slightly challenging.
Yes.
Ma'am, I want to ask something
Yeah.
about the physical symptoms of anxiety and depression. Is burning sensation, patient complaints often like these are burning sensation over the palm and the sole. Is it a physical symptom of anxiety, depression?
I mean, I cannot say that, right? Just say that is the symptom, but it
Mhm.
can be part of the distress state. But you have to rule out other causes of physical issues,
Okay.
like a neuropathic pain due to any cause. Also, it is a common diabetic neuropathy. Then it is also a side effect of many chemotherapeutic agents. So you have to look into all other causes which can cause, along with understanding that a psychological distress state also can bring in such issues. I would
Madam, how do
probably
you-
say that in anxiety, it's more of numbness and tingling.
Okay.
Like it becomes cold and frozen. No, like when you're very anxious, you become very cold. And
Mhm.
cold sweats. You say, fright and fight reaction.
Okay. Thank you.
Madam, how do you assess a person who is actually, like, for example, with the CVA, with the cerebrovascular accident, who is conscious but not able to respond? How do you assess, say, depression or distress in such patients, and how do we treat that?
So if the person is not able to really communicate, if you say the person has aphasia or some
Yeah.
other speech issues, if the person probably has also emotional issues because of the stroke, because sometimes they have something called emotional lability. When
Yeah.
they stroke, sometimes when the person is actually laughing, they start crying. Because of the stroke, they have this emotional lability that we call when person has a cerebrovascular accident. It is difficult, but then you also look into the history of the person, what the caretakers tell you, and also about uh, other aspects like sleep, appetite, and also expression. The person can express non-verbally the sadness, not even if the person is having emotional ability, how he mingles with others in the family, how he cooperates with them, how he cooperates with the treatment care given to them. Is he resisting that? Is he, how is this affect, the facial affect? All this is very important. So if you are doubtful that the person has a distress, I would advise you to bring in a mental health professional.
Okay.
Because post-stroke depression is very common.
Yes, madam.
Ma'am, and while conducting the bereavement meetings, as it involves more than during the mental health of the caregivers, any particular thing we should avoid asking to the attenders while conducting the bereavement meetings, like that? Anything particularly?
I would like to ask you what made you ask that?
Because while conducting the last bereavement meeting, while asking, I asked some attenders like, "How are you?" like that. How are you feeling love like that? Even for that one question, that attenders become I don't know, like she started very much crying, like those things, and she shouted like he didn't able to manage her at the present. And I don't know whether I am wrong or while conducting that, asking that question, I don't know whether.
Why do you think the person was crying or angry?
Recent loss of life.
So remember loss and grief that I showed you. The person is going through grief, so your job is to help them. So it is very normal that a person would express the emotions. So you should, I don't know, in communication skills. Have you had your communication skills classes? So how to handle angry patient, how to handle a person who's very emotional or crying person, is very important. So you do not think that I should not have asked this or that person should not respond to this. It's not that. So you also said appropriate question that you're asking, how are you feeling? Or how are you now? And the person suddenly gets angry or starts crying and says, why do you want to ask me this? And I'm not, saying something inappropriate. But then that shows that the person is distressed. So I would probably then say that I can see that you're very upset. Can we just sit down and talk about it if you want to? So just trying to give them a space to sit down. So once, see, whenever a person is angry, remember that that person is not going to be angry forever. Anger is something which comes and peaks and comes down. You can even think of your own situations where you get angry. You get angry, it stays for some time, and then you think, oh, why did I get angry? I shouldn't have done this, isn't it? It's very, unless you are, so something really vicious has happened. But normal anger states are always like that. So you actually then give that person that time. Tell her that, see, I do want to spend some time because I can see that you are very upset. Can we just sit down and talk? So if the person gives permission for that, give her the time, allow her to sit down and express what she's going through. So I don't think both were inappropriate. See, Dr. Rajagopal always used to say, you don't have to offer solution. Actually, we do not have solution. We are not some miracle kind of workers. We cannot just fix things. But what we can do is keep asking why, what, how. Your aim, your role is only to facilitate that process. So you keep asking, I can see that you are very upset. Can you tell me more about it? How can I help you? What made you cry now? So just keep asking those questions. The person herself will start telling you about it. Does that make sense?
Yes, ma'am.
Dr. Ravi?
Somebody has raised a hand.
Yeah,
Ram
Dr. Ravi.
Vikiran.
Uh, Good evening, madam. I just want to know regarding what you have said, the distress thermometer, which when translated into the vernacular language, either in Hindi or in Telugu, which is my native language, the words synchronizes with the pain. When we take the NRS scaling of the pain, we can ask even with this much, or this much. But the same thing when it comes to the distress, it stucks even when the nursing staff states, they get confused even when we the physicians, when we address the thing, it around, because the value which we mark like 1 to 10 in the distress thermometer, it more or less synchronizes with the pain. Very easy thing, or that we can exactly for the distress, or is there any demarcation line that can we have regarding the pain and distress?
So you were very, the sound was not really good, but I think what I understood from your question is that in terms of how sometimes when we use certain tools, we're not really able to get the scores. And sometimes I can understand, because sometimes distress thermometer does not have function adequately in our kind of culture settings. So I know that in certain settings, people ask with the paise, whether you have distress as
Yes,
10
yes,
paise, 10 paise, 50 paise, 1 rupee kind of thing.
yeah.
Like that, or as some score. So that is also okay. But I think the term that you do for distress should be figured out by your team, because what you can do is just not take any term that implies distress, but you should have some team discussion. You can actually do a research even for that you have some inputs from your team, from the community, from your volunteers, from your fellow physicians, to what actually distress means. Have a couple of terms which come, and then you can even try out a few and then decide on which term that you want to use, because it's very hard. I can understand. We did a lot of discussions to know in Malayalam what we should use. So it's very hard. So you need to find out for your own setting in your vernacular language. But then I think when you say that they get confused because it is similar to pain, then see, the thing is, that is exactly why I said that in spite of the physical symptoms, you should be able to discern what distress is. So in distress thermometer, the cutoff is 4 or 5. And that is why I said that you have to do it routinely and regularly, probably twice a month or every week that you can see the person. Because Even when the pain is, if the person's pain has come down and still the distress is there, then you know that the distress is psychological in nature. Am I being clear?
Okay, ma'am. Yeah, yes, ma'am. Yes, ma'am. Yeah. Thank you. Thank you.
Hello, ma'am. So in that case, if a person knows both the language, probably in Hindi as well as English, can we expose this scale in
Yeah.
Hindi first, later on on English language, so that we can compare it how the person feels the distress. This can help out in the research, maybe.
Yeah. That you can do. You can actually compare how people with the knowing same languages are responding both the tools. It's an interesting piece of research. So you can say how even the definition of distress or the term that is used can influence marking. Because see, distress thermometer is not a specific scale. It does not diagnose depression or anxiety. It is just a scale with face validity. Do you understand? I don't know if you know the validity of a scale can be because of the content it has, because of the construct of the terms, and because of also the face validity. Just because when you use, you can measure something. When you have face validity, you will pick up a lot of distress because everyone will say, oh, I have distress, I have distress. The sensitivity will be very high, but the specificity will be very low. That means specificity is what we say about the diagnosis. Am I making sense? That is, a tool like distress thermometer may have a lot of false positives. Is that clear?
Thank you, ma'am. Yes, ma'am. Thank you.
So it is interesting to know because, but why we say such a tool is enough is because it takes a short time and it is really useful in the clinical setting. You can't have a long questionnaire every time in the clinical setting, isn't it?
Madam, in a patient with severe pain, when we are trying to control the pain, in spite of very high doses of morphine or its other medications, when the pain is not controlled, we had a discussion the other day with another, a doctor who was giving a presentation, and he said that we have to think about emotional distress or psychological distress. How do you come to that conclusion that, okay, there is something wrong other than the physical pain?
That again is about the history of the person. Like when you're assessing the person, you should look into how the coping of the person. Again, it's all about how you assess the person, how he has been coping till now. Is there a distress state? Is there a risk for the person being anxious? Is there a risk of the person somatizing the pain? I think that is an important aspect in palliative care. I've been actually talking to Sunil about this, where there is a tendency sometimes for us to overprescribe analgesics when it is not actually an organic pain, but a somatoform pain disorder.
Yeah, yes, madam. This is exactly what I was trying. So we are trying to increase the dosage without actually.
Probably, if you're interested, if many of you are interested, we can speak about that in the next session.
Okay.
So if you can give me 1 or 2 topics, I can just focus on that. If sleep is one, sleep, then somatoform pain. So you can decide and let me know in a couple of days. You can let Sunil know, and then Sunil will let me know, and I can focus only on that.
Yeah.
And I'll just take a few minutes to talk about management of distress also. I'll complete this presentation, and then I'll go on to the I think probably only 2 concepts because I don't think we'll have time. I would prefer more of interaction like this so that you have your questions come up and then we can sort that out. Anyway,
I want to ask, ma'am, are you going to teach us regarding the mental health among the palliative physicians and how they can cope up?
I have not actually thought about that, it's very important. It's not only for palliative care. I recently saw a study where cardiologists, a good percentage of them have depression.
Yeah.
So I was telling my friend who's a cardiologist that you should do it in India as well. So, so I think all of us, especially the COVID situation and the post-COVID situation, we also have gone through a lot of personal changes in life, exposed to a lot of issues, and then also the work atmosphere has changed. There's a lot of burnout, grief. So mean, staff stress is burnout is a very important topic. So you can decide what I have to do, or otherwise Sunil has to give me 1 more hour in the schedule, 3 hours. Because we don't have time for discussing everything.
Anything else to be asked now?
Is it? Okay. Yes. Sunil, did you say something?
No, I was asking, is there any other question?
All
Okay.
right. If there are no questions, I will log off. Thank you very much.
Yeah.
I hope to see you on 26th, and I hope to get some input from you all regarding what I should be focusing on. Okay, Sunil?
Okay. Thank you, madam, for joining us
Bye. Bye.
today and
Bye.
making sense of distress and making us.
So I hope it was useful. That's most.
Yeah. Yeah. It's general concept.
Yeah. I think it's
distress
because
and,
it's something which you do not. See, I think it's also important to understand that your experience or your competence will improve only when you start practicing. So it is not something like if you start uh, looking for distress, identifying it, then you will become more and more efficient to do that.
Madam, one thing, is it possible to identify distress by looking at the patient alone? I mean, without questionnaires. What I mean to say is just by facial expressions and things like that, or the way they react.
If you have a good history, yes, of course, you can. I mean, we would be able to because we are trained to do so. We kind of, when we see people, we know that they are anxious, or we are able to pick.
So are there specific facial expressions which you're looking for?
Not really. I can't say because like any person can be anxious, so it's not that that can be a normal anxious also. It need not be a distressing state. But then when
I can be more specific. The reason why I asked was, for example, if we are monitoring that patient 24/7 without asking questions, but like, for example, like a facial expression camera, will we be able to pick up his nuances and find out whether he's in distress or not?
I don't think that we should do that. I think it should be an assessment which is looking into everything. So that is why I said it's emotions, thoughts, and behavior. So the behavior is also important. We cannot just rely on emotional expression. Of course, it's important. I'm not saying it is not important. A person very anxious, we can pick it up very well. But we should not rely only on that. I'm saying we should have a much more integrated way of approaching the person in terms of.
But that can be a guideline to further inquiries, isn't it?
I don't think so. You should just rely on emotional expressions. Then we would just say, look at a person if he's anxious, that is distress. But that is not so. That is why we are using screening tools and all these guidelines. But of course, it will help you to understand that this person is nervous. More than that, you need to explore that what is going on. That is exactly why I said, let us not just look at emotional reactions. Let us look into more as a concept of distress.
Thank you.
Importance is not only the emotional expression, it is whether he's coping. Coping is important. That we cannot identify by looking at the facial expression.
Yes.
All
Thank
right.
you.
Okay, thank you, madam. So we'll see next on 26.
Yeah. And please give me some time by end of this week, whether if you can bring up certain topics, then I can focus on that.
Yeah.
All right. Thank you.
Thank you, everybody. Step in.
Thank you everyone for joining in. Thank you, Chitra ma'am. Please do use the feedback form also to pitch in the topics of your choice for what Chitra ma'am just said. So just reminding that we will having a session tomorrow as well. No session on Friday, but we will have a session tomorrow. The reminder has already been sent over to your emails. Please do look out for that. So see you tomorrow again with another interesting topic with yet another eminent faculty joining in. See you again tomorrow. Bye-bye.